I'm delighted to be here. I'm Shadab Rahman, assistant professor of medicine at Harvard Medical School and a lead investigator at the division at Brigham and Women's Hospital in the Division of Sleep and Circadian Disorders. I have a few disclosures, but nothing directly related to this work that I'm presenting today. To start off, I'll remind ourselves that by some estimates, we spend an awful amount of time sitting indoors, to 90% of our day spent indoors. And that typically means that we are also in an illuminated area, typically not by natural sunlight, but rather by artificial lighting or electrical lighting. And primarily, those lighting standards and conditions are set for keeping vision as the main priority in mind. But we know that light exposure, visible light exposure, has a whole wide range of physiological responses. Typically, when we think of lighting, even in practice, thinking about light as something bliss related to mood lighting. It makes us happy, sad, calm, excited, etc. But there's so much more that happens with lighting in response to light exposure. And it really starts off at the very minute level with changes in gene expression, going to protein changes, hormonal changes, endocrine changes, and then which then all circles back to affecting our mood, alertness, neurobehavioral performance, and cognition. And so this scope of lighting really goes well beyond just changes in mood. And we need to start considering its impacts and studying its impacts on the various different health outcomes that are affected by lighting. And I'll again remind ourselves that we can design interventions and we can try new things, but they really, for them to be effective, for them to have efficacy and to be effective, they need to be grounded in the science. And so over the last few decades, we and others obviously have carefully characterized how the different properties of light affect human physiology, ranging from spectral conditions. You'll hear a lot about spectral tuning today, intensity, duration, pattern, timing, history, etc. And then taking that basic physiology that we've learned, you can then design interventions which are efficacious and effective. So the simple guidelines that we follow when we're designing our interventions is a dichotomous split between whether individuals are we designing the intervention for a space where individuals will be sleeping or not? Because if they're not sleeping, then presumably they're there to be doing some work and to be active and alert. And so the priority there is maximizing alertness, which has a slightly different approach than when the individuals will be sleeping in that environment or space as well. If they're working and sleeping in the same environment, then for some portion of the time when they're active, you want them to have maximal alertness. But then when it gets closer to bedtime, and certainly during bedtime, you want to tune down the lighting so that it maximally promotes sleepiness. And so what we essentially do is that for environments where individuals are not sleeping, we use high melanopic intensity lighting, so high intensity, blue enriched, throughout the work hours, based on physiology in the lab and field trials. We know that maximizes alertness and productivity. And if it's an environment where individuals will be sleeping as well, then, as I mentioned, during the wake hours when they'll be working, they'll again have the same blue enriched or short wavelength enriched bright light. And then close to bedtime, we'll make it dimmer and make it more blue depleted or short wavelength decay. So with that basic principle and science in mind, let's look at some application that we've been doing. Now, the application of lighting, specifically making the days brighter and the nights dimmer, the contrast between night and day, it's nothing new. It's been going on for a long time. These are just a handful of examples, some seminal work in the field where it's being tried, this approach has been tried in various different healthcare settings. So from care homes to in the NICU and the PICU, etc. In most trials, they have had positive results where the outcomes they were measuring were improved by light exposure. And this goes back, these examples are from the 2000s, and then obviously we know phototherapy itself for depression, for example, has been used clinically since the 70s and 80s. So there's a long history, rich history of using light to improve health outcomes. When we go into an intervention, into a new space, there are certain key things to identify, starting with who are your stakeholders. And in the healthcare setting, at least, there are at least three key stakeholders that we need to identify. The care recipients, the patients or the residents, care home residents, etc. Then there are the care providers, the clinical staff, the support staff, etc. And then there's obviously the institution itself. What benefit does the institution get from implementing such lighting interventions? And then we need to identify the key performance indicators, the KPIs, because the different stakeholders will have different indicators or performance indicators that are meaningful and impactful for them, and for them to judge whether the lighting intervention has been efficacious and effective and essentially worth it. And the one key thing that we have realized is that there is no one-size-fits-all solution. Yes, we have general guiding principles, but every environment has its own unique challenges that need to be addressed. And you have to really tailor your intervention based on the needs of your client, essentially. And for data sources, you have multiple, especially now with all the electronic data that's available, there are multiple sources from where you can extract data to look at the impact of your intervention. So I'll start off with an application where people do not sleep. We and others have done extensive work to show that if you don't get enough sleep, your cognition and neurobehavioral performance and productivity is affected. And this translates through the medical field as well. For example, when physicians have limited sleep or restricted sleep because of their work shifts, it leads to increased medical errors. In the US, and globally, medical errors are an immense burden, both to the patient, the care recipient, to the institution and the care provider as well. And it's costly. Given that premise that light exposure can improve improve alertness, we wanted to test whether an outcome such as medical errors, which would be a major KPI in the healthcare industry, does light exposure, can you do something with lighting to improve or reduce the number of medical errors? And so in this particular trial, we leveraged an opportunity where the university hospital ICU was getting an upgrade from fluorescent lighting to LEDs. And the primary driver for them was to make the switch wasn't efficiently. Well, we took that opportunity to now put in some of the, what I call sleep and circadian informed lighting intervention principles in there. So basically what we're trying to do is, and again, this is an environment for individuals that want sleeping. We're going to look at the impact on nurses and medical errors. And we're trying to maximize their alertness. So for 24 hours during the day, because it's a 24-hour operation, obviously, what we did was made the lights brighter and more blue and rich. So we went from 51 milliamp EDI in the fluorescent state to about 208 milliamp EDI 24/7 with the LEDs. We looked at about 1,000 ICU admissions, identified 302 errors, and this was objectively identified by 2 independent physicians and adjudicated for errors. And what we found was that overall, there was a 6% reduction in medical errors, 10% reduction in potential errors, 13% reduction in harmful errors, and 33% reduction in high severity harmful errors. So this is first proof of principle that applying the basic physiology that we know about light on human sleep and circadian rhythms can translate to actual KPI changes in an applied setting. So then I'll move on to an application where an environment where individuals do live in sleep. So for this, we again grouped care homes that were going to be changing their lights over from fluorescent to LEDs. And in this case, the primary outcome of interest was falls, because as we all know, falls highly prevalent, especially in the aging population. And just like medical errors, falls are tremendously burdensome for the care for the individual. It reduces the quality of life, increases their care cost, etc. And then obviously the overall economic burden is extremely high just from falls as well. There are many different interventions that have been tried for reducing falls of varying different ranges of efficacy. But the impact of lighting, why did we think that falls would be affected by lighting in the first place, is because the underlying physiological traits that impact fall risk are things like sleep, mood, activity, cognition, etc. And these have all been shown to be benefiting from judicious use lighting. So the study design, we studied 4 care homes, a pair of care homes under each parent company. And then we collected data pre-upgrade for 12 months, collected false data. And then 1 care home for each company got the LED lighting while the others stayed on their standard fluorescent lighting. And we collected false data for another 12 months after the intervention. And just to quickly go over the kind of population, so you can see this is an aging population, average age of around 83, and they're about a quarter, 30 to 40% of the individuals have dementia. So what do we actually do with the lighting? So in the control condition, so we have the phototropic blocks presented here and the melanopic blocks presented here in the dashed line. And you can see basically in the control setting, it's static throughout the day, both in the common areas as well as in the bedrooms. In the experimental settings, we made it more dynamic. So during the nighttime, midnight to 6, during the nighttime, it's dim lighting, then the intensity increases, and in the process, the melanopic strength of the light source increases and then dims back down in the evening. So it was a multi-step process in the common areas and more that kind of change in the bedroom areas. By and large, what ended up happening was that we increased the light intensity during the day between 65 to 70%, and we decreased the light intensity during the night, ranging between 80 to 33%. When we started off, both the experimental and control sites, the fall rates were very similar to or very close to the US average. Following the lighting intervention, there was a reduction in the number of falls per patient day in the experimental, but not in the control, which resulted in about a 43% overall reduction in fall rate in the experimental sites with the lighting intervention compared to the control sites. And this remains significant even after we adjusted for age sets in the presence of dementia. We had PNL come in and do their own independent evaluation of energy efficiency and energy savings. And there was significant energy savings by converting over to, and a lot of the energy savings came from just the sheer conversion, and then some portion of it, a smaller portion of it, came from the dimming that's also involved with the dimming of the lights at night. And this is readily available online, their independent report, and you can view it if you are interested. But this is another trial that we've done more recently in collaboration with PNNL, and this was in a behavioral health unit. And in this particular trial, it wasn't just a change in lighting, but the full environment. They basically went from an old building to a new building. The old BHU was, again, fluorescent-based lighting, static throughout the day. In the new BHU, it's a new building, but as well, there's now dynamic lighting that changes throughout the day using the same principles. This is a very complex program that was used. We had nothing to do with coming up with this program. This was chosen by the architectural firm in consultation with the institution itself. But in any case, we evaluated the impact of a dynamic schedule. Again, same principle, dimmer lights at night, less blue enriched, lower melanopic strength. And then during the day, you're increasing the light intensity to overall increase melanopic lights. It was about a 15-month trial. We collected lighting data, both using wearable and static sensors. And then we had staff surveys. The nurses participated in the study, and we collected data on them. And then we had patient data as well, collected at 3 different times. So the nursing data or the staff data were collected under the old condition and the tunable condition, and patient data was collected under old, static, and tunable. And static here refers to there was a portion, a couple of months, where they had moved over to the tunable lighting, but the tunable system was maintained static throughout the day. Some demographics, very small sample sizes here, 20 individuals or so in the 2 different conditions. And then the patient demographic, again, fairly small sample sizes, 20 to 30 individuals. And this is a relatively short-term stay of a week or so. as opposed to the care home study, which was all long-term stay. But this particular trial gave us the opportunity to see how the care providers are also impacted by the lighting. And so the first thing that what we found was how they rated the lighting environment. And by and large, we saw an obvious improvement between the old and the tunable. And going to tunable, all the environments were rated as excellent to good, whereas in the old fluorescent environment, these ratings from the nurses of the different lighting of the different areas mainly fair and poor. When we looked at their mood itself, positive affect and negative affect of the staff working there, we found that there was a trend for improvement in positive affect with this tunable lighting in place. And there was actually a significant reduction in the negative affect, indicating that the mood is improved in the staff as well working in this environment. Then focusing on the patients themselves, and remember, this is a behavioral health unit. It's a mixed environment with individuals with different medical conditions that are there. But one of the clinical outcomes that are followed is the suicidal ideation score. And so when we compare that on average across the 3 different conditions, we find that there's a significant reduction in suicidal ideation score with the tunable lighting compared to the old or even the static condition. And when you split this by sex and you look at it as relative to essentially the length of stay, that the suicidal ideation score in the tunable lighting has a faster recovery than in the other 2 conditions. So by and large, this is what was applied by and large in various different settings. Now we see that implementing sleep and circadian informed lighting interventions does have positive in health outcomes. And we and others have examined this application in clinical settings, commercial settings, residential settings. And like I said, in various different modes, there are different opportunities that are amenable to this sort of intervention and having benefits from these interventions. So I'll just quickly end acknowledging all the fantastic collaborators that I've worked with, the different institutions, the funding agencies, and thank you very much for you.
Thank you very much for that. That's wonderful stuff. You made the comment that people are either sleeping or they're active. And I wonder to what extent that is taken as an absolute and what you're counting as being activity. Because if I'm sitting down reading a book or if I'm running around, they're both activities, but they are very different. How varied were you in terms of activity, bearing in mind your audience, the people you were working with?
Yeah, that's a fantastic question. And I think this is where the first thing is that there isn't a one-size-fits-all solution. So there is tailoring involved. Having said that, in the interventions that I showed you, we took a very simplistic approach. You're either awake or you're asleep. And when you're awake, you're active, quote unquote. In other studies, which I haven't presented here, but they have been published, for example, in the NASA research analog, where there were crew members going through a 45-day mission, there you have this range in activity. They're awake. Sometimes during the day, they're really active doing their work. They even have exercise bouts. And then towards the evening, they're awake, but they are calming down. They're reading the books, watching a movie, etc. So there we took a more graduated change in the lighting scheme, right? When they were really awake, active, working, the lights were maximally blue enriched and bright. And then closer to bedtime, there was one step. 3 hours before bedtime, we dimmed the lights, but to normal room intensity level. And then 2 hours before bedtime, we brought it down even more to about 18 or so melanoptic EDMs. So again, based on what your needs are, you may need to implement a more systematic, graduated, tailored intervention.
Okay, thank you. I think this is a decent follow-on to that. One of the situations that Shelley and I have found in the care home environment is what you count as being the circadian cycle of the day, as to whether you work astronomically, you work with the seasons, or whether you go with the daily routine of the house, which tends to be equinoctial, 6 a.m. to 6 p.m. We've spoken to Russell Foster about this, and defining what we mean by the circadian rhythm of an environment still seems to be a little bit up for grabs. But how did you approach that?
We took the latter approach where we went by the institutional needs. Right. Because and there are pros and cons to taking both approaches, obviously. So I don't want to come up with a hard and fast rule. Again, I think it depends on what our objective is and what's pragmatic, what will work, right? So if the objective is to mimic nature as close as possible and then follow the seasonality in the photo period, etc., fantastic, that can be done. But if the objective, operations and keeping things on schedule, and you know that you have to follow a certain schedule, then pragmatically, it's better to follow that schedule so that on average, things are moving in the right direction instead of implementing a lighting schedule, which now creates a conflict with your work schedule, and then you're always struggling. And then ultimately, that just leads to poor effectiveness of the intervention.
On that basis, then, what did you find that daylight was a help or a hindrance in that, in terms of whatever daylight contribution you were getting into the various rooms?
Yes. In the care home, it was a really sad, at least we did the studies in Wisconsin where it can be pretty long nights. The amount of daylight that comes in is almost negligible, right? If you take a meter and you read it next to the window, sure, you're going to get a daylight exposure. By the time you're halfway into the room, there's barely any daylight that's going to have a measurable impact. It still works as a cue. It primes the system, contrasting between day and night. All that is there. I'm not taking any of that psychobiology away. However, the actual alerting impacts of lighting, there's barely any daylight that's reaching. Even in common areas, there were situations where they had large, big windows with light coming in, but again, by the time you're halfway into the room, the light's not reaching guys.
Okay. It looks like the daylight contribution is the same regardless of which side of the Atlantic you're on. So thank you very much for that. Shadab, thank you.